Okay, thank you all for joining us in person and online. Today is a special day for us because this is when our second year class gets to present their research proposals. For those of you who are still learning the research curriculum, throughout the 4 years, the residents work on a project with a faculty mentor, and you will see in a few months when the fourth years present their projects. So these second year projects, the goal is for this to be background in methods. We're not expecting them to have results yet. And really, this is for faculty and other residents to give suggestions, ask questions so that we can improve these projects and give them support moving forward. We have a busy day, so the goal is for residents to have no more than 5 minutes for their presentation, and we'll have a couple of minutes for questions for each one. And we'll just get started. Okay, so our first presenter is Aaditi Naik. She is presenting on code status documentation for G1 oncology patients. Resounding applause.
Okay, hi everyone. Let's see if I remember how to talk after a night shift. So my project is on code status documentation for gyn-onc inpatients. I've been doing it under the mentorship of Dr. Kushner. So rates of code status documentation and inpatient admission notes and/or orders are as low as 20 to 54% in the literature. This refers to all inpatient admissions, not just gyn-onc. There are a lot of studies showing that having a code status order entered improves the quality of a patient's care. Studies showed that there is a significant decrease in ICU admissions, in CPR attempts, and in the number of code blues for patients who have a code status order entered within the first 48 hours of their admission. So it really can make a difference as to how a patient spends the end of their life. And have them experience some less aggressive care. There is a scarcity of literature about rates of code status documentation in gyn-onc inpatients. And so this is where our project comes in. So this was a QI project that was initially thought of by Dr. Montemarano. It's looking at inpatients admitted to the gyn-onc service between October 2018 and August 2023. We looked at all gyn-onc inpatients, excluding the ones in surgical short stay that just were receiving same-day postoperative care before they went home. The interventions, there were actually 2 of them, occurred in January 2022. The first one was a teaching session with the residents on how to discuss code status. And the second one was a change in the admission order set to include additional options for code status. So there's now a section in the order set that says code status and offers the options of full code, no CPR, no intubation, or no CPR may intubate. This section and these options aren't mandatory, so it is still possible to admit someone and to go through the order set without selecting a code status, but at least they're now present. Our comparison group was inpatients admitted to the gyn-onc service in the 3 years prior to the interventions. And then we have 1.5 years of post-intervention data that we are collecting. So the primary outcome is looking at the proportion of patients who are admitted that have a code status order placed at the time of admission to the inpatient gyn-onc service. The options are full code order, no CPR, and then full code no order. And that just means for any patient that doesn't have an order put in at the time of admission, they will automatically become full code, but it distinguishes it in the system as full code no order to know that that was not an intentional entry and more of just a default. Additional variables we're looking at are age, race, insurance status, cancer diagnosis, stage or recurrent status, length of admission, CPR attempts, ICU admissions, whether they had a palliative care consult prior to admission, whether they had a palliative care consult during admission, and whether they died in the hospital. So the hypothesis is that after the two interventions, there will be an increase in the proportion of gyn-onc inpatients who have a code status order entered during their admission when compared to that proportion pre-intervention. And so that was our first aim. The second aim is to look at the clinical demographic characteristics and clinical outcomes that are associated with presence or absence of a code status order in the EMR. And so that is specifically looking at, for all of our post-intervention patients, we're going to do a chart review and see if there are specific subsets of patients that are disproportionately not getting a code status entered. So is it that we talk about this less with patients who are less sick? Is it that there are racial disparities? These are things that we're trying to figure out. So in the pre-intervention period, there were 479 people admitted to the gyn-onc inpatient service, excluding short stay. In the post-intervention, there were 148. And so we know that our documented code status pre-intervention was 16.7%. So only 17% of patients were getting a code status order entered during their admission. So using that, we calculated that we can detect a difference of 13% post-intervention with 95% power. So we can detect as low as a 30-ish% rate in code status afterwards. Future directions, like I mentioned, we want to identify any factors that are associated with patients not having a code status entered so that we can focus future cycles of the QI project on those subsets of admitted patients who disproportionately lack a code status order. And thank you to Dr. Montemurano, Amy Godecker, Dr. Kushner, and the Gyn-Onc Clinical Research Program Managers. That's all.
I'm curious if there's any variables in your chart review that you think will be difficult to collect or difficult to characterize.
Yeah. Yes. So I think insurance status might be a little difficult to collect just because knowing the insurance status at the time of admission might be difficult if it's changed. Also looking at prior palliative care consult, I think will just be a little bit more time intensive and having to comb through notes to figure that out. But overall, we tried to pick variables that we think are reasonable to be able to collect. We know that with our patient population, there's probably going to be a really, really low rate of certain variables. So for example, we don't have a lot of patients who die in the hospital. We don't have a lot of patients who get CPR attempts. So that might be a little difficult to analyze differences given that our subsets are going to be so small.
Can you talk about how you're running your PDSA cycles, like how often you're doing them and what you're doing to try to figure out, check for improvement?
Yeah. So far we've just done the one, and now we're doing 18 months of post-intervention data collection. The aim is to make a run chart, kind of see whether the interventions had sustained improvement. So was there just a temporary improvement in code status documentation right after the teaching session? Is that something that's been sustained to 18 months out? And then we can hopefully use that information to decide, do future cycles mean just repeating that teaching session more frequently, or do future cycles mean trying to add on something else?
Okay, perfect. So our next resident is Naomi Roselaar, who is working with Dr. Cutler.
Good morning. My project with Dr. Cutler is called Changes in Management of Pregnancy of Unknown Location, otherwise known as PULs, among Wisconsin OBGYNs following the June 2022 Dobbs decision. A little bit of background. Pregnancy of unknown location, or PUL, is described via ACOG as a transient state and not a specific diagnosis during which a pregnancy has not met diagnostic criteria for an intrauterine pregnancy or ectopic pregnancy. And there have been multiple prior studies assessing changes in the medical practice following the passage of laws that limit or restrict abortion care. However, there's a lack of literature on the extent to which abortion restrictive legislation affects the management of PUL specifically. The study we propose is a pilot survey study. It will be a web-based study that will be collecting pilot data for future qualitative research. The population that we are aiming to target is OBGYNs, practicing in Wisconsin. And these will be OBGYNs who have managed PULs prior to and following June 24th, 2022, the date of the Dobbs decision. This study does not have an intervention, but has a comparison. And the study will explore the changes in practice of the management of PULs before and after the Dobbs decision, which is why we want to have OBGYNs who have practiced and had that practice before and after that date. An example of this is a patient scenario with management now versus management before the Dobbs decision, and seeing if people might have different responses. The primary outcome is the percent of physicians managing PULs that report that their practice has changed since the Dobbs decision. Secondary outcomes include ways in which PUL management has changed, and primarily we're going to start by looking at negative versus positive changes. And then we're going to look at how patient experiences have changed due to these changes in practices. Those may include autonomy, stigma, number of tests or encounters that patients have to go through if there is a change in the practice. Our hypothesis is OBGYN physicians managing PULs have changed their practice since the Dobbs decision. And our specific aims are to assess whether physicians have changed their management of PUL since Dobbs, characterizing how the practice of PUL management has changed, and characterizing how the factors associated with the changes in PUL management since Dobbs. And these factors may be patient factors, some of the ones I talked about before, or physician factors that we'll be assessing through some demographics. The sample size of our study, we think will be about 315 participants, which would be 30% of 1,052 members of Wisconsin ACOG. This is a limited population, and there are limitations to this in general because there are only a certain number of OBGYNs in Wisconsin, and not all of them manage PULs, and not all of them have been managing PULs during the time period that we are looking at. Our plan to identify the participants includes two ways. The first is an email advertisement in the Wisconsin ACOG newsletter. So that will be sent to all 1,052 members. Keep an eye out in your inboxes, please. And then also in person, we're lucky to have the Wisconsin ACOG meeting coming up. And so there will be a flyer there with a QR code that will make the survey accessible. The web survey is going to use UW Qualtrics. We're building it with the UW Survey Center, who have been very instrumental in this. So please look out for the survey to come. And I very much appreciate all the help and support of these people. Thank you.
I have to figure out how to become a Wisconsin ACOG member, I think. Yeah. For probably lots of reasons. In the next couple of weeks. So obviously the biggest concern, for surveys is thinking about responses. Are you going to do anything to help encourage people to respond, sometimes sending multiple ones, incentives, things like that?
Yes. We talked a lot with the Survey Center about what works for incentives and doesn't. And although the studies kind of show that you need a very high incentive, like $50 or $100 to get people to help, we're hoping that our incentive of $10 will get people to fill out the survey. So yes, there's an incentive.
Other questions?
Naomi, when you're thinking about, sometimes like a survey is the best way that you can get data collected. But when you're thinking about writing the manuscript, what are some of the biases that you'll have to account for, or at least discuss, that occur when you're doing this for this project in particular?
So I think there's biases in the population that will respond. Certainly targeting Wisconsin ACOG in general doesn't even target all of the people practicing OBGYN in Wisconsin. So that in itself is a bias. We're just starting out with our sample size and population. And then certainly who is actually going to respond to this. People who have stronger opinions about changes or feel that they have made a change may be more likely to respond. So that's certainly something to think about.
The first one is called selection bias. The people who decide to respond or who are recruited may be biased because they're more interested. And then recall bias, right? Someone who has a very strong feeling about the Dobbs decision, either positive or negative, may be more likely to respond to your. So just, something to think about as you're moving forward with manuscript preparation.
We did also discuss that it's not just OBGYNs who manage PULs when we were thinking about this project. Ultimately, we decided to keep this kind of limited population, but I think that's another consideration, that it's not even just OBGYNs.
Yep, survey studies are hard, so good job.
Okay, perfect. Next, we have Kharmen Bharucha, who is working with Dr. Barlett and Dr. Wager.
Good morning. I will be presenting on the clinical and molecular determinants of response to PARP inhibitors maintenance for primary and recurrent ovarian cancer. My mentors are Drs. Barlett and Wager. I am very grateful for their help. So PARP inhibitors have changed the way we treat ovarian cancer. To review, PARP is an enzyme that helps repair single-strand DNA breaks. Without PARPs, the single-strand DNA break is converted to a double-strand break. If the homologous recombination is proficient, then the double-strand break is repaired and the cell survives. If it's not present or deficient, the double-strand break is not repaired and the cell dies. So if PARP is inhibited, the cell can't repair itself and it dies. So that's why patients with BRCA mutations and HRD derive the most benefit. But there's some patients who derive little benefit despite molecular indications suggesting otherwise. And we know that indications for PARP inhibitors are changing. The Paola trial demonstrated that olaparib plus bevacizumab compared to just bevacizumab in first-line maintenance for ovarian cancer increased progression-free survival. So the question we'd like to answer is, among patients with epithelial ovarian cancer, what's the frequency of long-term and short-term response to PARP inhibitors? To answer this question, we did a retrospective chart review of 124 patients who received olaparib maintenance therapy for epithelial ovarian cancer between 2014 and 2021. We collected clinical and molecular data. We defined short-term responders as people who experienced progression less than 6 months after initiating olaparib, and long-term responders exhibited response for greater than 2 years. We also obtained molecular analysis with germline BRCA 1 and 2 status, HRD somatic testing, and strata selective comprehensive genomic profiling. We used Pearson's chi-squared and Fisher's exact and Kruskal-Wallis tests for the statistical analysis. We hypothesized that the short-term response to PARP inhibitors is higher than previously reported and differs based on setting of PARP use. We want to assess the incidence of PARP resistance. And we hypothesize that patients with long-term and short-term PARP response will have distinct germline and somatic molecular characteristics. Thank you.
Thank you. Any questions?
So the molecular characteristics are going to be determined by their strata profile. Is that what?
We had HRD BRCA 1 and 2 and the strata.
And the strata profile. And is there some prior literature to suggest that, or is that just a concept that you just trying to find distinct populations?
Prior literature to suggest
that the genomic changes will be different in these two groups.
Oh, I know that the Paola trial stratified based on BRCA status and HRD status, and they did find a difference in response to olaparib plus bevacizumab compared to just olaparib.
Okay.
Other trials have also looked at HRD versus BRCA. I would need to read more to find out about the other specific.
Perfect.
I'm sure it exists.
What other characteristics do you expect could also impact someone's response?
If they've had platinum sensitive or resistant ovarian.
I don't know much about this, but I would also imagine there's like other age or medical comorbidities and things like that. Are you collecting those as well?
Age, comorbidities, surgery, if it was primary or interval debulking, if it was an optimal or suboptimal debulking.
How did you determine? I think you mentioned you guys have identified 124 patients to look at. How did you get to that number?
Dr. Wager found patients who were treated with both PARP inhibitors at UW, and then we looked in their charts to see if it was for breast, prostate, ovarian cancer.
Okay, so that came from like a convenience sampling of
all of the patients at UW that have been on PARP in that time frame?
Between 2014 and 2020.
Okay. And that'll be something, to chat with your mentors about how, any sample you have to, kind of describe how you got to your sample, right? And how you identified that specific number of people. And it sounds like this is not for, power analysis, but good.
Thank you. Perfect. So our next presenter is Kaitlyn Anderholm, who is working with Dr. Eliza Bennett. Good morning. So I am working on a project to identify changes following a protocol implementation for the treatment of iron deficiency anemia in pregnant patients. And we are hoping to optimize and delegate responsibilities. So anemia in pregnancy is the most common hematologic abnormality in pregnancy, and the most common cause of anemia is iron deficiency anemia. Some studies estimate that worldwide between 30 and 40% of all pregnancies are affected by iron deficiency anemia. And it's modifiable. We can change iron deficiency anemia and treat it fairly straightforwardly. Complications of iron deficiency anemia in pregnancy include low birth weight, preterm delivery, perinatal mortality, and postpartum depression, among just kind of feeling crappy because you're pregnant and you need more hemoglobin. This is a quality improvement study. The intervention is the implementation of a new protocol at UW Health Clinics in which RNs are tasked as drivers for the identification and initiation of treatment for iron deficiency anemia. It was actually just approved and implemented in the past week, so hot off the press. The protocol is basically tasking RNs with that responsibility in order to take this kind of onus off of physicians or advanced practice providers' plates, in that everyone knows that inbox bloat is real. So utilizing RNs and their skill sets is being done in the hope that we can sort of delegate that responsibility for improved patient treatment and outcomes as it relates to iron deficiency anemia in pregnancy. The population of interest is pregnant patients receiving care at UW Health Clinics from OBGYN and family medicine providers who are identified as having iron deficiency anemia in pregnancy. So this is done by routine prenatal labs, looking at the CBC and seeing if anemia is present, and then making sure that there aren't other, factors or drivers of that anemia, other potential causes. And our plan is to compare pre and post protocol implementation to see rates of correctly identified iron deficiency anemia and successful treatment. Our outcome of interest is, as I said, the rate of pregnant patients with iron deficiency anemia receiving appropriate treatment, both before and after implementation. Our hypothesis is that utilizing RNs to coordinate and initiate treatment of iron deficiency anemia in pregnant patients will result in increased rates of appropriately treated iron deficiency anemia in pregnancy. And our aims are to determine the prevalence of iron deficiency anemia in pregnant patients at UW Health Clinics, and then to quantify the impact of this new protocol, leveraging RN skill sets. This is very much in its infancy, as implementation of this protocol just kind of happened within the last week. But some kind of ballpark sample sizes is approximately 150 pre and post implementation patients. That may or may not be feasible depending on kind of what we find the rate of iron deficiency anemia to be now that this protocol has been implemented. And then we are going to identify patients via chart review. Inclusion criteria would be they have to be pregnant, they have to doctor at UW Health Clinics, and then they have to have iron deficiency anemia. And exclusion criteria would be secondary causes of anemia outside of iron deficiency anemia. There will likely be other exclusion criteria identified as we sort of start to parse out that population a little bit more, whether it be we may kind of stratify by high risk of pregnancy, multiple versus single gestation, things like that. But we haven't quite made that distinction yet. We'll collect data via chart review. Our primary outcome is the rate of properly treated iron deficiency anemia within 1 month of diagnosis. Obviously, when you're doing studies on pregnant patients, like time has to pass. And when you're doing a resident research project, like time is of the essence. And so kind of figuring out those primary and secondary outcomes, whether we want to wait till like time of delivery versus if we look at when iron deficiency anemia is identified and diagnosed, and then the duration that it takes for that patient to receive proper treatment. We are kind of figuring out how we'll manage that time component. And then, as I said, secondary outcomes could be rate of anemia present at the time of admission, or potentially frequency of comorbid conditions at the time of delivery as it relates to iron deficiency anemia. Thanks.
I just have a couple of questions. One, some of it relates to the fact that we actually have a delegation protocol and have for many, many years. It's just been updated. So I'm curious as to whether, so nurses have been doing that delegation, but now they'll be able to, basically start the iron orders for IV iron in a more systematic way. And the cutoffs have finally been updated to eliminate the race-based stratification that should never have been there. All good things. But I'm curious if you're going to, if your endpoint is going to be that the protocol active at the time was followed, or because it sounds like you're looking at your endpoint is whether it was followed rather than outcomes. And I'm really not certain that we would expect to see a different outcome in how it's followed. Maybe we will, but I'm curious. I don't quite follow the plan. And then I also have some questions about how you have it set up with a pre and post cohort, because that is that's more of a research setup rather than a QI setup. And I'm happy to talk a little bit more about that as well.
Totally. Yeah, that makes sense. I think that our like primary and secondary outcomes are maybe a little bit kind of amorphous at this time, but I hear your point, and I think that maybe we could like tailor that a little bit more and have it be, with nurses being able to order the IV iron supplementation. Okay, so what's the follow through on that? Like how does that impact the success at which like patients, the time frame that they then get to receive that IV iron supplementation, if kind of the efficiency of placing those orders and kind of starting that protocol is improved with this change. But yeah, we can definitely talk more. I'd love to hear your thoughts on kind of how to make this a little more meaningful and specific.
Yeah, and then just the other thing to think about is QI studies are typically not done with a pre-post cohort like this, which is, intuitive how we think about research. And you may want to look at a pre-cohort like, but typically QI studies, you're going to do your cycle. So you're going to say like, we're going to look at 10 patients a month, 20 patients a month, because there is no statistical sample size to calculate. And your goal is you need to set your SMART goal, which is going to be a specific outcome. So you'll have to like hone that down and say our goal is to improve the rate of IV iron administration for a hemoglobin less than or equal to 9.5. Our baseline is at 30%, and our goal is to increase it to a post-implementation rate of 80%. And we're going to look monthly at X number of charts, and we're going to see each month how many patients meet, if we can meet that goal. And then if we can't, we're going to try and figure out each month what it takes to get there. So I'm super happy. I know we have limited time this morning, and happy to sit down with you and kind of look at this more from a QI standpoint if helpful. But those are just a couple thoughts for this morning.
Awesome. Yeah, thank you.
I just want to chime in quickly too about pre-post studies and statistical analysis. And I'm sorry I'm late, but if you have not had a consultation with biostats, then I would recommend it, because you can't compare a different cohort pre and post, and there's not a comparative like t-test that you can really actually do. So if it's not a randomized prospective project, you really can't do a research pre-post comparative analysis, I guess is what I'm saying. And it fits better with what Dr. Spene is telling you to do.
Totally. Yeah. Thank you.
Just have one more quick comment. Can you hear me?
Yeah.
That one of the things that you may consider doing is looking at first of all, what are you doing to determine iron deficiency in pregnancy?
So you would do the CBC. If anemia is identified, you would get a ferritin and see if there's, you would also want to do like electrophoresis to make sure there's not another component of like a thalassemia or something. So, and that's, that's what we would do.
So one of the things, and I'm happy to help work with you too, is that one of the things that we may look at doing, I'm not sure that we're doing it right. I think that what we may need to do eventually in OB is to, in addition to CBC, check the ferritin level, okay, at the initial OB visit. And if their iron stores are low, even if they don't have anemia, look at seeing whether if we treat them, whether we reduce their chances of getting anemia throughout pregnancy. And therefore at birth. And so I think that the other thing is looking at outcomes eventually in terms of whether you haven't affected any of the maternal severe morbidity markers. And so so I don't want to, talk too long about it, but I think this is a great area right now that's really hot in terms of management. Another thing is how are you treating these patients? What kind of iron preparations? Because you're going to be able to get with certain iron preparations like carboxymaltose a lot more iron in at one visit than you will with iron sucrose, which you have to have them come back for multiple visits. And I'm not sure if we have iron carboxymaltose here. So looking at the iron preparations to see if we can give all in one big swap instead of having compliance issues of patients having to come back multiple times. So that may be a little bit more than you want to hear, but I'm really excited about iron and anemia right now. And so if you want me to kind of give you some kind of suggestions, don't hesitate to. Okay.
Yeah, I would take everyone has lots of comments. So thank you. If we are running out of time, feel free to email me other thoughts too. I'm happy to hear everyone's ideas for improvement. I don't know if we have time for more questions. Yeah. Sounds good. Thank you. Thank you.
Okay, our next speaker is Christina Dudley, who is working with Dr. Bharucha.
Hello. I'm talking about pelvic infection after egg retrieval in patients with endometriosis, which I'm working on with Dr. Bharucha. So just for a little bit of background, pelvic infection after egg retrieval is pretty uncommon, but when it does happen, it's serious. And it's believed that the risk is highest in patients with endometriosis, although there's really not much evidence to support this. Some clinics do give antibiotics to all patients, both with and without endometriosis, who undergo the procedure. And this did include generations until about 1 year ago. And at that time, infection control, at the request of Dr. Bharucha, sort of agreed against prophylactic antibiotics and created a prophylactic regimen for patients with endometriosis, which includes IV Suboxone 2 grams pre-procedure, doxycycline 100 milligrams twice orally on the day of the procedure, and then an alternative of doxymetronidazole if a severe IgE-mediated beta-lactam allergy. So the study design that we're working with is a retrospective cohort study looking at patients who underwent egg retrieval at Generations Fertility Clinic between January 1st of 2011 and now. Our exposure is patients with endometriosis, and the comparison group is patients without endometriosis. And the primary outcome is rates of infection in patients with endometriosis compared to those without. And then an additional outcome is looking at rates of infection in those who did and did not receive antibiotic prophylaxis prior to egg retrieval. And the time that this changed was November of 20. So we're thinking about patients who received the antibiotics beforehand and then those who did not receive them after. So similarly, our specific aim, number one, is to determine rates of infection in patients with endometriosis compared to those without. And then also to compare rates of infection in those without endometriosis who did and then did not receive antibiotic prophylaxis. So our hypothesis for these aims for the primary outcome, so 1A is overall rates of infection will be low after egg retrieval, and then 1B is that patients with endometriosis will have higher rates of infection than those without. And then for the additional outcome, for 2A, overall rates of infection after oocyte retrieval are low for patients without endometriosis. And then 2B is there are not differences in rates of infection between those who did and did not receive antibiotic prophylaxis. So we have about 1,663 patients who underwent egg retrieval generations from 2011 until now. So that will be our population. In terms of the data collection itself, so ICTR will help with a REDCap data pool using ICD-10 codes for endometriosis, egg oocyte retrieval. We're also going to be looking at other confounding risk factors with things like age, BMI, history of diabetes, perhaps antibiotic allergies that could affect which antibiotics they received. And then some additional manual extraction will be required to determine who received these antibiotics after November of 20 from procedure order sets. Statistics, just thank you to Amy Godecker, who was probably listening. We were talking about this a little bit. So thinking about a chi-square test for independence and then a 2-sample test of proportions, basically looking at yes to endometriosis and then yes or no to infection. And then if we do use kind of those groups, age, BMI, we'll plan to use a t-test when comparing those. And that's it. Any questions?
Thank you. Questions?
So if you were presenting this to me and I'm an editor of a journal, and you're presenting your manuscript, right? One of the things I might want to know is if you relied on ICD 9 and 10 codes for data pull, right? What were ICD 9 and 10 codes designed for? Were they designed for data? No, they're designed for billing. So an editor of a journal might say, you relied on something that wasn't designed for data pulling. How did you ensure that something that wasn't designed for data pulling was valid or accurate? So because things like you're relying on the ICD codes for like things that are associated with infections, you may want to consider like 10% of doing a manual chart extraction, which is annoying, but med students are helpful. And saying, yes, we reliably, the data that we pulled using ICD codes, when we did a manual extraction, they were like 90% reliable. So we can say that this data is accurate. This is something that I'm seeing more and more as we are relying on ICD codes, and the editors are saying, did you do a manual extraction to make sure that the data was valid and accurate? So there's something to consider. It's annoying because it's labor intensive, but it will help your study be more successful with getting published.
Thank you. It's really helpful.
I think another important thing to think about is what is the baseline rates of infections like in this population of folks getting egg retrieval and specifically at generations. Do you know that? Because it'll also just be important in figuring out, like, do you have enough data to actually look at this outcome?
Yeah, that's something we'll have to look at to see if we have, enough power behind this. I'm not exactly sure off the top of my head. I'll have to talk to Dr. Bhagavat about that. But yeah, that's a good point. It's obviously not like a huge population, and hopefully there's not too much infection. So we have to look into that.
Well, and hopefully there's not a lot of infection, but if there's not, then you need a lot of patients. So that's the downside.
I know. Yeah, that's true.
I think this is a good time to mention for all residents that we have the opportunity to have Shapiro medical students over the summer who can help with data collection. This is like a lot of work for people who have to go in and do a lot of chart review. And so planning that ahead of time with your mentors, having a Shapiro student can really be invaluable.
Great idea. Yeah.
Any other questions?
Thank you.
Excellent. So our next presenter is Jeannette Larson, who is working with Dr. Hanks.
Our project is looking at sterilization rates at a single institution in Wisconsin before and after the Dobbs decision. I'm working with Dr. Hanks, and then we also had a Shapiro student, Camille Phillips, who has done an amazing job. For background, on June 24th, 2022, our first day of residency, the Supreme Court decided Dobbs v. Jackson, which overturned Roe v. Wade and essentially banned abortions under most circumstances in Wisconsin. This is done through the 1849 Wisconsin criminal abortion statute. Anecdotal reports following this decision suggested an increase in sterilization after the Dobbs decision, but limited data supported this. So for our study design, we are doing a retrospective chart review. Our population is all patients who had surgical sterilization from June 24th of 2016 to June 23rd of 2023 at Meritor Hospital and UW Health. This is inclusive of all forms of tubal sterilization, and we plan to obtain an additional IRB to look at vasectomy rates as well. 2016 was selected as the start date to account for trends over the Trump administration and then the COVID-19 pandemic. We included ages 18 to 55 and excluded immediate postpartum procedures and those at the time of cesarean. Our control group was total outpatient benign gynecologic surgeries, which we chose to look at to see if sterilizations increased in proportion to the total outpatient benign gynecologic surgeries or if sterilizations increased out of proportion to that total. For statistical analysis, huge shout out to Amy Godecker, who has been helping us with this. We had chi-squared and then a p-value for statistical significance set at 0.001. This was IRB exempt. Our hypothesis is that sterilizations have increased post-Dobbs, especially among younger and nulliparous patients. Our aims are to demonstrate how the Dobbs decision has impacted sterilization trends for people in Wisconsin and to identify changes in patient populations that are seeking sterilizations pre and post-Dobbs. Our current sample size is a total of 1,087 patients from June 24th, 2016 to June 23rd, 2023. And we expect the sample size to increase as we're planning to add another year of data through June 2024 and vasectomy data. This data was collected manually by chart review of all gynecologic surgeries at Meritor in this time period with procedure indications, including sterilization, desire for sterilization or permanent sterilization, and excluding immediate postpartum or at the time of cesarean. We currently have the data from Meritor through June of 2023 and we'll collect for another year, as I said, and we plan to obtain an additional IRB to look at vasectomies within the UW system.
Thank you. Question in the room.
Love the project. Thanks, Nettie. I was wondering why you decided to exclude postpartum sterilization.
Yeah. Our thought process when we were talking about it was that people who are getting a postpartum sterilization may not be thinking about like the same rationale as people who are coming into our office for like a laparoscopic tubal consult, or there may be other factors that go into like choosing postpartum versus interval. We excluded C-section specifically because we thought of it as opportunistic. And that was kind of the reasons why we did those.
Yeah, it may still be interesting to collect that to see if there are trends that we may not have anticipated from an obstetric standpoint too.
Yeah.
Yeah, that's interesting. And I hope that you've seen the abstract that was accepted for the Society of Family Planning, where with the huge increase in office visits for sterilization consults.
Yeah.
Yes. Very powerful data. Great.
Other questions?
I'm curious about the p-value of less than 0.001. Can you talk about why you picked that versus a different significance level?
That was after discussion with Amy. I'm not 100% sure why that value was the one. We had talked to her after looking at all of our data and prepping a presentation for District ACOG.
Hi, this is Amy.
Hi, Amy.
Hi. I noticed that when you presented too, and I don't remember selecting that. So I'll have to look into that again.
That's great.
That would be unusually stringent. I think if we were talking, it might have been when we were talking about power. And given the sample size that you have, what change would you be able to detect? And I think it might have been that given the sample size that you have, you're going to be able to detect a really small change.
That makes sense.
At a high power. So that might have been where that came from, but I will look into that again.
Okay. Thank you.
Thank you very much. Okay, our next presenter is Dr. Rusha Bajpai, whose mentor is Dr. Rose.
Okay, hi everyone. I'm Rusha, and my resident research project is gynecology, oncology, adnexal mass referral patterns at UW, and my mentor is Dr. Stephen Rose. Just a little bit of background. Over the last decade or so, the gyn-onc department at UW has seen an increase in adnexal mass referrals. Currently, they get about 100 to 120 referrals in a year. It has been noted that many of these cases do not meet referral criteria, but no formal analysis has been undertaken. All we have is like anecdotal evidence. ACOG recommends gyn-onc referral for postmenopausal women with elevated CA-125 or premenopausal women with a very elevated CA-125, ultrasound findings suggestive of malignancy, like ascites, nodular or pelvic fixed mass, or evidence of abdominal or distant mets. Studies show that these guidelines serve well in identifying late-stage disease, but not so much early stage, and that's mainly due to lack of early signs and markers of disease, and there's no like screening process really for ovarian cancer. So this is a retrospective chart review of UW gyn-onc adnexal mass referrals over a 12-year period. Our study population is all adnexal mass referrals from January 1st, 2011 to December 31st, 2022. The UW Clinical Research Data Service team has given us 1,100 MRNs that fit this criteria. And that kind of lines up with the 100 to 120 referrals per year. Of these referrals, we will analyze what percentage of cases met ACOG referral criteria. This includes menopausal status, physical exam findings like a nodular or a fixed pelvic mass, imaging findings such as a complex cyst, ORADs 4 or 5, distant mets or ascites, and tumor markers such as a CA-125 higher than 200 in premenopausal and higher than 35 in postmenopausal patients. There are no specific exclusion criteria. Our primary outcome is to determine each year how many consults met the referral criteria. We will then compare the yearly prevalence of guideline consistent referrals to track trends over this 12-year period. A secondary outcome is determining the yearly percentage of referrals that underwent surgery, and of those identify the percentage of benign, malignant, and borderline pathology. Another secondary outcome is the percentage of referrals with confirmed malignancy that were not surgical candidates due to advanced stage disease or comorbidities or such. Our hypothesis is, or our specific aim is to determine what percentage of gyn-onc adnexal mass consults truly met ACOG referral criteria. And our hypothesis is that from 2017 to 22, there will be fewer adnexal mass consults that met criteria as compared to the 2011 to 2016 timeframe. And another aim is to determine what percentage of referrals underwent surgery, and of those, the pathology type like malignant, benign, or borderline. And our hypothesis for that is that from the 2017 to 22 timeframe, gyn-onc has operated on an increasing amount of benign adnexal masses as compared to 2011 to 2016. Our methods, information will be collected from UW Epic and stored in an institutionally secure REDCap database, and we already have our MRNs stored in that database currently. Analysis will be completed by a department statistician. We still have to meet with them and go over all of the specific tests we will be running, probably like chi-square and t-test and all those things. The sample size provided to us, like I mentioned, is about 1,100 patients, consistent with the 100 to 120 referrals per year. And we suspect this is adequately powered, but we'll go over that with the statistician as well. And then the study has been confirmed for IRB exemption. There's no consent that is required from these patients. And then next steps include building the REDCap database itself and meeting with the statistician prior to data entry to make sure how we're entering the variables is consistent with how they will be doing their analysis. And we have a medical student on board who will be assisting with chart review for all these MRNs.
Question up front.
Top of this, but we recently, with the implementation of the kind of new ORAD system that we are doing, the end of your time frame could get a little muddled because of that, because ORADs has kind of changed how we receive and triage some of these things because it's providing us additional information about risk of malignancy. So for that kind of tail end, like your 2021 to 2022 portion could be muddled by that, and that could have an impact based on what you're looking at. Because this is, not designed to look at that implementation of ORADs, but ORADs absolutely is impacting the clinical question you have. So just something to kind of tease out. And Dr. Rosa is very familiar with that, but it'll be important for kind of that last year and a half or so of the data you're collecting.
The red cap, I'm sure we could include one of the questions like year of referral and then help determine.
Yeah. And then Dr. Wallace and I and Liz Sadowski are, along with some of our benign guidance, are part of that ORADs group. And we can provide you exactly when ORADs was really implemented. And then you guys can kind of decide how you want to tackle that or maybe even leave it out. But I just don't want that tail end of your data to get muddled because it absolutely has changed how we are accepting or denying referrals.
Couple of questions in the back.
Rusha, so an N value of 1100 is a big study for a resident. So my question is, and it seems that you have a lot of clinical data, like you have biochemical markers, post-map, things that are not easily assessed. It sounds like you're going to have chart review unless there's a registry that I'm not aware of.
No, it's going to be a lot of chart review. You're correct.
So my question for you is, why do you need 10 years? If the question is, if the question is what percentage of referrals meet ACOG criteria, why do you need 10 years? Did something happen in 2016 where you need the data prior? Or could you just look at the last 5 years and cut your N value in half? And will that amount of data answer your question of what percentage of referrals are meeting ACOG criteria? Because I really worry about having an N value where you have such a deep pull that has to be done manually, the scope is very large. And do you really need that much data to answer your question?
Yeah, I think that's a really good point. The year or the time frame itself is pretty much arbitrary. We were thinking at 2016, ACOG had kind of adjusted some of its adnexal mass referral criteria, but actually looking at it, not that many adjustments were made enough for us to suspect a true clinical difference. So we were thinking, 10 to 12 years would be adequately powered for us to assess trends over time.
When you say the other thing, Dr. Hermbach, I know your hand is up. So there's no intervention, so you don't need to be powered, right? Power tends to be something we use to help guide an intervention. And if you're just trying to get epidemiologic or observational data, you don't necessarily need to be powered. Just something to consider.
If you're looking at a percentage, you could calculate how many people you need to have a tight or wide confidence interval. And that's something that Amy could potentially help you with.
Thank you.
I was just going to say the same thing that John did. You want to pick time points where something might have really happened. And you could potentially just take 2005, 2010, 2000, you don't have to look at 1100 charts to answer this question. Your hypothesis is that the referrals are going up, despite the criteria. And so, we're just trying to look out for you.
Yeah, thank you. I appreciate that.
Any last questions? Excellent. Thank you so much to all the residents and all of the mentors and the whole research team and staff. Have a great day.